I'm Matt Bonds. I'm an associate professor of global health and social medicine at Harvard Medical School. I'm an alumni of the Burke Fellowship, and I'm a co-founder of Pivot, which is a healthcare organization in Madagascar. I was an assistant professor at the time in the department of global health and social medicine. I had started this organization, Pivot, with some other people, and I was in a little bit of a transition. So I had originally been the executive director of Pivot, and I was transitioning to the scientific director and focusing on the research. And the overall arc for me was Pivot is a healthcare delivery organization. My first priority was to ensure that it was delivering quality healthcare in Madagascar. But the science was central to that. And it was really important for me to take the time to focus on the research and as we professionalize the leadership of the organization. So I was basically transitioning to this period of leading the research in Madagascar. And the Burke Fellowship itself, at that time, we were trying to build the overall research capacity in the organization. So Pivot now has about 400 employees. Then it probably had around 200 employees. The MO of our organization is integrating the delivery of healthcare with the science and research. And that's like a really intentional process. So the Burke Fellowship specifically was focused on training our staff, me and my team, training our staff, lower level, like more junior staff on the research team, like data collectors, and on the programmatic team on how to engage in the research, how to formulate research questions, how to design research studies, how to understand the literature, so that we can do a better job bridging the research with it. Pivot is it was started. It's a 11-year-old organization, healthcare delivery organization. We work in Madagascar. We're modeled largely off of the work of Partners in Health. That's where I had originally had my training, and one of the other co-founders also came out of Partners in Health. We partner with the Madagascar government to strengthen the local health system, and the goal has been to establish a model health district. So that district has 200,000 people, 400 community health workers, 21 primary care centers, 1 district hospital. And we've expanded. So the first 10 years or so, first 9 years, was focused on this 1 district. Since then, we've been invited, we've been encouraged, we've been requested by the Madagascar government to expand to 3 districts. So now we're in a region of about 1 million people, 3 district hospitals, 90 health centers, 2,500 community health workers. And the core of our work is strengthening all aspects of that system at all levels. So hospitals, primary care centers, community health workers, those are the levels. And then what we call these horizontal systems, infrastructure, staffing, training. And then our value proposition and sort of the reason why HGHI is connected to this, the reason why Harvard is connected to this is around the research and producing the evidence base for how to improve the healthcare system of Madagascar. Yeah, so now we're in a big moment. So it's 10 years or as I said, we've gone from 0 about 11 years ago to over 400 now, plus the 2,500 community health workers. And it's real. Like we're recruiting, in the process of jointly recruiting with the Ministry of Health, these 2,500, we're about 1,500 community health workers in. We've expanded our footprint from the 1 district to the 2nd district, and there's a 3rd district we're working towards. It's a moment of reflection as we're trying to refine the work that we're doing. We can't do it in the exact same way that we did 1 district at the larger scale. The government of Madagascar is evolving and changing. The overall landscape of global health and the funding for this work has changed. So it feels like a very vulnerable time for places like Madagascar Madagascar has the lowest per capita spending on healthcare in the world. So the total spending on healthcare per year per person in Madagascar is $16. So compare that to, say, the US, which is about $15,000, or Rwanda, which is maybe about, depending on who you ask and how you ask, around $100, $150. So it was hurting before, and it's going to be hurting more, like as a country in terms of being able to support its own health system. But what we're working on showing is that with a relatively modest amount of resources and smart design, smart programs, the connective tissue across the system, like meaningful change can happen. And so we've published many of these results, and we've shown remarkably 30% decrease in under 5 mortality, 50% decrease in maternal mortality. We've tripled the utilization rates of health centers per person. So we've shown that like this is not like a fantasy. This is a real health system that's having hopefully permanent, lasting trajectory of its healthcare. From the beginning, our approach was this is a program we have to build the systems and the people and the partnerships locally, right? And so that was always the value, the goal. We'd never had a large staff based in the United States or internationally. And so in some sense, it was business as usual, right? Like we don't need to fly back and forth all the time to do the work. The people who are doing the work are there on one hand. And then also on that one hand, same hand, is it's like, the pandemic was particularly bad and jarring for the country of Madagascar, but it wasn't so different than honestly what Madagascar goes through. Within the previous 5 years, there's a major pneumonic plague outbreak. The largest measles outbreak in like the last 50 years happened in the area, and then on top of that, there are these various forms of political instabilities. There was a coup in 2009 that had long-term consequences on the overall system. There's a lot of natural disasters. This is kind of the common story, but it's true. Like these cyclones are coming, they're highly destructive, they destroy homes, they destroy roads, they destroy hospitals and health centers. And so there are a lot of just crises, if you want to call them that, like bad things happen. And the pandemic was another one, you know? And so we were kind of used to it, kind of ready for it, and at the same time, it was still a very stressful, very intense time, just like it is anywhere else, where a lot of questions, a lot of like unknowns, a lot of uncertainties on what's the appropriate level of response, how much should people be going back to the work, how often, how much can people travel back and forth. A lot of the challenges and uncertainties we face in the U.S., Madagascar faces as a country as well, except for without rapid tests and vaccines that ultimately came there. So in the context of the fellowship, in that time period, there's always these two things you're trying to manage, which is you have to figure out how serious the situation is, right? Like how big should we mobilize? How much of the organization should redirect its focus towards managing a crisis? That's one question and requirement. And the other is, okay, we have a long-term goal here, and it's to strengthen the health system. And this is another illness, right? It's a respiratory infection, and we deal with respiratory infections all the time. Many children die of pneumonia, for example. Tuberculosis is a big problem. And how do we stay focused on what the longer-term goals are? Maybe even use this as an opportunity to be even more focused on strengthening lasting health systems. That was the logic of it. And so when I was writing this fellowship proposal, I didn't, interestingly, I was kind of, my recollection, although it's so foggy, is that I was thinking the pandemic would be a non-factor in the proposal, right? I was like, okay, now I'm proposing something in the next couple of years, and but it was a huge factor because it meant there was no international travel and stuff for at least a year. The Burke project was these workshops that we were using to train local Malagasy researchers and practitioners. So we did a series of workshops. The workshops were training specifically on how to conduct research. And the reason why that's important is because if I step back a little bit, the way that I see the big challenge in a place like Madagascar is we are often not necessarily asking the right questions, right? We need to know how to ask the right questions. And I'll give you an example of that, and then I'll explain why this project is so important. When I first went to Madagascar in 2012 was my first time in Madagascar. I went to this local health center that's right by our offices, our headquarters now. And it's a common story, sadly, but we were visiting this health center. The health center was structurally okay, not bad. It was converted from an old school building, but it had nothing. There was like one staffer, a medical doctor. The pharmacy was almost totally empty. There were almost no patients in the health facility. There were a couple of beds that were empty, but there was one girl who was dying of malaria, cerebral malaria, like a young girl, around 8 or 9 years old. And so that year, that was 2012, there were 60,000 articles written on malaria in the world at that time. If you Google Scholar, if you were to go on Google Scholar and ask, okay, what do we know about malaria? What are the right questions? How are we answering those questions? What's the science that we need? You could read 60,000 articles on Google Scholar, and none of them would have solved that particular problem, right? Very few of them actually, I think, are rarely sort of addressing the particular context, the particular issues of a place like that. And it's amazing how the difference between reading the scientific literature and facing a problem, and you're wondering what are scientists doing right now? Why are we trying to come up with a new intervention when old interventions are working, right? Or old medications are working, right? Like what's the right question for this particular issue? And so of course, there's a whole lot of questions, right? There's all kinds of reasons. Like anyone can understand, well, there's probably a lack of resources, right? Malaria drugs cost money. There might be an educational or sensitization issue. Like she probably should have been treated sooner. You know, her family probably should have taken her earlier. She had cerebral malaria. There are issues of like, well, maybe the staff need to be properly trained. Maybe there's supply chain issues. Maybe there's an issue of who should be paying and when. So there's a whole host of, and then there's questions of why is malaria endemic, and actually it's been rising since then. So malaria prevalence has been rising in Madagascar. So you could ask all these questions. And so for me, the focus has been, okay, we're going to find out this is how we're going to find out the right questions. So we're going to work on solving this problem, right? So we're going to work on ensuring that kids who have malaria are treated for malaria, and we're going to do that at a scale that's relevant to the Madagascar government, that's aligned with how the health system is functioning, and we're going to discover in this process what's working and what's not working, right? And so you're discovering the questions by trying to implement the solutions that are supposed to be done, right? And so a lot of that is straightforward in the sense that the Madagascar government has protocols, has guidelines. It's obvious what drugs are supposed to be used. It has norms for how the health system is supposed to be staffed. It has funding schemes, including for poor people, with who they refer to as indigent populations. And so what it doesn't have is a health system that functions according to the way it's designed, according to its own policies, right? So it's like the very first step in this is let's implement the policies as they're designed, as they are recommended by the World Health Organization, and let's discover if that's working. And if it's not working, if it needs to be changed, right? So a country like Madagascar can't improve the design of its health system if it's never even able to implement what it's doing. So in order to do this, figure out what's working, what's not working, you need implementers, right? You need the actual clinicians and the program managers to be a part of the research team, right? The people who are grappling with what kind of budget do we really need? Like how far does a community health worker need to work? Is it practical? How much do we need to be paying community health workers? These are all legitimate research questions, right? But they're also just very straightforward programmatic questions, which is we're trying to build a team of community health workers, we're trying to train them. So most of the activities that an organization like Pivot does with the Ministry of Health, most of our activities are themselves legitimate research questions, right? Is this the right activity? Should this be national policy? And so, but as everyone knows who does research, formulating a research question that actually produces generalized results is hard work, right? And it's like it's its own challenge of like, okay, how do you right size the problem and that you're trying to solve, the questions that can be answered, right? And so what we're trying to do in this is we had been doing ongoing research with programmatic people, with managers, and with our research staff, but we're trying to both improve the dialogue across the organization so that researchers are in constant conversation with implementers, program managers, clinicians, and that clinicians who almost all of them, not just clinicians, but programmatic staff, almost all of them are really interested in research, and many of them have been on research papers, but they didn't have training in research. They didn't know how to read a research paper. They don't really know, like, well, just because a question's interesting, it doesn't mean you can answer it, right? And so it's really about it was about getting everyone on the same page. So we did a series of workshops that were taught by me and people that I train. Many of them, or some of them, actually all of them through Harvard, but some of them are Malagasy, so Malagasy postdocs, Harvard postdocs, and training them on how do you read a paper, how do you do study design, how do you read the literature, how do you interpret the literature, how do you read the papers that we've written at Pivot, right, and how do you interpret them, and how do you ask questions about them, right? So they'd be co-authors, but they didn't know how to provide feedback on even very easily. So it's been about that process, and that the fellowship itself allowed for a process of a couple of years to do these workshops, and it's just been an ongoing process through different mechanisms, yeah.